Hello, everyone, and welcome to our roundtable, A New Groove for Teaching Pathology in 2021 and beyond. I'd like to say this virtual event has been organised by the Pathologist and is kindly supported by Cubtech. My name is Rich Whitworth. I'm the Content Director of TechSed Publishing, and I'm joined by a fantastic panel of experts. And I'll go through their names now. We've got Michael Arnold. We'll call him Mike in the call. He's Medical Director of Anatomic Pathology at the Children's Hospital, Colorado, and Associate Professor of Pathology at the University of Colorado. We've got Shivayogi Busnurmath, who is co-chair of the Department of Pathology and Dean of Academic Affairs at St. George's University School of Medicine. We also have Amy Fox, Professor of Pathology and of Pediatrics at Albert Einstein College of Medicine and Vice Chair of Clinical Research and Faculty Affairs, and Division Chief of Point of Care Testing and Outreach Labs at Montefiore Einstein Department of Pathology. We have Tiffany Hebert, Associate Professor of Pathology and Residency Program Director of Anatomic and Clinical Pathology Education at Albert Einstein College of Medicine. And finally, Jason Innerhofer, who's a lead pathologist assistant and faculty preceptor for Rosalind Franklin University and a clinical instructor for the University of New Mexico. And I'd just like to note that Jay recently got the Rising Star Award from AAPA. So that's something to celebrate before we get underway. So without further ado, I'd like us to begin our discussion, folks. I hope you're all ready and that I don't need to use the immortal line, "You're on mute." But if I do, I don't think anyone will be in any way offended. So I think probably what everyone's wondering is why we have this particular panel of experts gathered. So I think it would be nice for us to perhaps go through your background in pathology education, and we'll do that not via who appears first on my screen, although that may be the case. We'll do it in alphabetical order because that seems to make somewhat more sense, and I'm not sure how you'll appear on everyone else's screen. So, Mike, can you kick us off with your background in pathology education?
Sure. So I think as everyone's experienced in the last year or so, the teaching that I've done has changed quite a bit. I had, before the pandemic, done largely in-person education and large conferences, and I dabbled a little bit into some virtual conferences. I actually tried it once with a group in India. But during the pandemic, that really became the focus of educational activities I was involved with. I was involved with the College of American Pathologists when they began their virtual lecture series, the CAP Virtual Path, last summer. And I'm really pleased to have seen how that's continued and grown. And I also got involved in pathologists.com, which was the brainchild of Dr. Kamran Mirza and a medical student, Cullen Lilly, at Loyola University. And that's been a phenomenal success. It's had hundreds of thousands of page views for that website. And the goal has really been to bring those in-person experiences as best we can to a virtual online module where there were virtual slides that we uploaded. There were questions and explanatory videos as part of that. And I think that has really been a direction that a lot of efforts that everyone's been involved with has grown in terms of moving towards virtual things that will not only be interactive, but enduring.
Great, thanks, Mike. Bruce, you're next on my list. And just a reminder to come off mute as well.
He's on mute.
Sorry, you're on mute, Bus.
Thank you, Rich. I've been involved in teaching medical students and pathology residents, as well as residents in clinical medicine over the last nearly 50 years. And my initial 18 years were spent in India at the Postgraduate Institute of Medical Education in Chandigarh. And then I've been moving around. I've taught at Oxford in the UK, mainly pathology residents, and Toronto, University of Toronto at the Liver Pathology Center. And then I taught both medical students and residents when AIDS was breaking out in the early 80s in Nigeria. And then for about 4 years, I taught medical students in Muscat, Sultanate of Oman in the Middle East. And I was asked to start a brand new pathology residency program there. We started it and got it accredited by the Royal College of Pathologists in London, UK. And for about last 25 years, I've been teaching predominantly medical students and guiding the curriculum at St. George's University, Grenada, in the Caribbean. My main interesting aspects of teaching technology was one, outsource education to the students, give them a set of expectations and make them learn it actively by themselves. Our charge was to make sure that all our students at Grenada have to go through the USMLE step 1 before they can start the clinical training in the final 2 years. And that is a clinical problem solving type of multiple choice questions based on pathology, which is about 70% of step 1. So we have been able to move from a pass rate of about 64% to somewhere around 95% over our period here. So there are many methods we used in our lectures, in our small groups, etc., to make sure that they become active learners and the pathologists start in a clinical reasoning, clinical problem solving fashion. And then when the pandemic hit last year, our 1,000 plus students in the pathology course were distributed across the globe, right from Caribbean, North America, Europe, Middle East to South Korea. And we had to, because we are an international school accredited by multiple organizations, so we had to make sure we meet our accreditation requirements, which meant several small groups every day, which are documented for participation, active learning, and our examination standards, which were administered online to make sure that these group of students don't lose their accreditation status. So it's been very exciting to do the virtual teaching, virtual examinations, making sure they are participating actively. So I can share some of those experiences with you. Thank you.
Thank you so much. And yeah, we certainly will, I think we have to touch upon COVID-19, and we'll do so in some detail later. Amy Fox is next in my alphabetical list.
Good afternoon, good morning, whatever time of day you will wind up watching this. My focus actually has been a little bit different, probably than many people on this call, and really it has been the faculty. It has been the faculty in every facet of teaching and getting through the last year and a half as unscarred as humanly possible. And yes, as you said, we'll get to that a little bit later. But one of the things that became very clear to me was, regardless of how well skilled our faculty were in public speaking, and of course we have a faculty at various stages in their career, beginning, mid-career, and senior, one of the things that became very apparent as we moved to this Zoom experience over the last 18 months was that not everyone was an effective speaker in that modality. And so it became very apparent, at least to me and the rest of our senior leadership, that we had to do something. And so as we watch this unfold, we actually have contracted with someone who will be teaching our entire faculty how to be an effective speaker and really understanding your target audience. And that actually brings us directly to the ability to distinguish between students, residents, other faculty, perhaps even donors, and the lay public. So that's just one aspect of how everything has changed for me personally in the last year and a half, is how I approach programs with faculty. And the other interest and actually title that I hold is Vice Chair for Clinical Translational Research. And instead of moving forward with our programs, our projects that we normally do with our residents, we actually took a break. And two of our faculty who are very engaged in teaching and research took part in a course at our medical school during the pandemic, and actually became certified in teaching clinical translational research to our residents. And that program, I'm happy to say, will begin in earnest in July with didactic teaching, still to be determined in person or Zoom, but they are more than capable of doing either. And then we'll move into the project phase sometime in the fall. But I think that we've all had to take a pause and figure out new ways to approach our teaching, and not only for our residents, but really for each other.
Thank you, Amy. Great response. Tiffany, you're next.
Hi, thank you. Thank you for this opportunity. I've been at Montefiore Health System for about 19 years. I came here as a resident, and since I've been here, education has been my passion. The program as a resident allowed me to be an education chief resident, which allowed me to interface with the medical school and be involved in medical school teaching at that level. When I became an attending, I was for several years a course director for the reproductive systems course. It's a MS2 level course. And during that time, I was exposed to different teaching modalities such as team-based learning, self-directed learning, a lot more active engagement with students. And I spent several years as well as the associate program director for the residency program here. And now I'm the official residency program director. And as a residency program director, I've been very involved in curricular development. We completely overhauled our curriculum and created a much more accelerated pathway through residency training that allows for a fourth year customizable year and also has multiple opportunities for interactions with clinical teams as a third year. And we've also created an online onboarding curriculum that actually started several years before COVID, but it was very handy when COVID came around. But that had a lot of interactive cases and videos. And we found that that sort of interaction with the students of this generation is much more retained than your traditional didactic talking at someone. And so one of the things that I would like to work on and hopefully hear from you all is more ways to make our learning environment and more active learning environment, particularly when you're giving didactic instruction.
Thanks so much, Tiffany. And last but by no means least, Jay, can you give us your little intro and how you got into pathology education? And a reminder of the mute button.
Okay, so I actually grew up with two uncles who were pathologists and both legally blind. They both had myopia. And in the summers, I used to go visit them and watch them do autopsies and surgicals. And that's how I kind of initially got interested in pathology. I went to New Mexico State, got a degree in biology, a minor in Spanish. And then when I did get into PA school, I was up in Connecticut at Quinnipiac University. Did 2 years there, got my master's, and I rotated through Yale, Columbia, a bunch of other hospitals, and got really good experience up there. And then I've been here in New Mexico ever since. As far as pathology and education goes, it's been my passion as well. And my main goal has always been to teach the residents and the PA students to be able to make that connection between the clinical history, the preoperative diagnosis, and the specimen in front of them, and be able to make that correlation and make sure they, are including all the pertinent negatives and the age of the patient and those kind of things. And so I've been really involved in education, love it. The past several years, I've been kind of experimenting with video and that kind of thing. And when the pandemic hit, the AAPA knew I did some of these videos and stuff. And they contacted me and said, hey, if you get a chance, can you make some of these videos for the PA students because they're not able to go to clinical labs and those type of things. So I spent a whole month because we're so low on volume. I spent a whole entire month and I made about 24 videos on how to gross a variety of specimens, and between leg amputations to mastectomies to gallbladders, appendix, you name it. I did these videos. And then the AAPA, they were very helpful as well. They had a panel of other pathology assistants who looked at the videos and did some editing or suggested some editing and asked for my approval. And we had that done. And then these were all put on the website, on the AAPA website. And these are also videos that I use here at work. I have a network folder, a resource for not only the pathology assistants like myself, but also the residents and the PA students. And they can go to that folder anytime, pull up either a video or a PowerPoint or a sample dictation, and really aid them in engrossing and that type of thing. So that's my background.
Thanks so much, Jay. Well,
sure.
Thank you all for your sort of intros and your I guess your reasons for being interested in pathology education. One thing that strikes me listening to all of your stories is the amount of passion. So before I sort of dig into questions, I wonder if you could all pass some sort of comment on the need for passion in education, because I think some people teach and some people love to teach, and I think there's a real distinction there. And I think certainly when it comes to times of adversity, the passion becomes more essential. So does anyone have any comments on that, or whether you agree or disagree? Any thoughts on that concept?
Enthusiasm is infectious. And when you're in a room or listening to a lecture, or even at a bench side with somebody who is enthusiastic and pointing out why this is interesting and what this means to the patient and making it relevant to you, all of those things make it so much easier to learn. It's actually difficult to learn when you're with someone who's not really into what they're doing and they're just kind of running through the motions. And I always try to, it's funny because I used to do a little intro when I was doing the medical student teaching with my lecturers. And one of the points that I told them about being prepared was smile, show that you're happy to be there. And it
Right.
really does make an impact on when you see it, when you get the evaluations back from the students, that they really felt that that enthusiasm.
Thank you. Anyone else with a comment on a quite an abstract concept, I admit?
Hi, Rich. I think I would put it more strongly, is that the biggest disservice we do as faculty is killing the interest of medical students who come very eager to become good doctors, especially in the field of pathology. You try to replicate what's in the books and information, and we're trying to make pathologists out of them in medical school, when actually they should be learning about the pathologic basis of disease and clinical applications. And as Tiffany said, if we just dispassionately recount what is in a book in front of the students like a pope, without really giving life to it with our own life experiences and our own patient stories, you're actually killing their interest. And even among residents, I think they see the passion very easily for teacher. Fortunately, now we will come to technology. We can have resources across the globe with excellent teachers, irrespective of whichever tiny corner of the world you are. And if you have a good internet connection, we can get access to several faculty who are going to teach with a lot of interest and personal stories to connect. So I think it's the most important thing, not really the knowledge of pathology. Thank you.
Thank you.
I'd like to add to that if I can. Since, as some of the people on this call know, I came to pathology sort of as an outsider. My original training is in pediatric infectious disease, and I came to Montefiore many years ago to run the virology laboratory, and that morphed into many other things. But I think that for me, at least, one of the things that I found so fundamentally important, especially when it comes to pathology, is communicating that at the end of every laboratory test, clearly, for those of you who do anatomic pathology, I think it goes without saying, but for a laboratory test that many patients take for granted, I think they really need, I think both our clinical colleagues need to understand what it means to do that. And we need to understand that at the end of every single test that we do is someone's mother, someone's grandmother, someone's brother, someone's cousin. And I think, to Tiffany's point, because she is one of those teachers, I know for sure, that when you convey that message to your students, they get it and they say, wow, I didn't know that was pathology. I think I could be a pathologist. So how do I know this? So about now, we're going on our 10th year. We founded the Montefiore Einstein Summer High School Research Program. And I don't think it was by accident that the home for that became the Department of Pathology. Our faculty made an extraordinary impression on so many of these high school students. And they, for the very first time, understood that not only could they have careers in nursing and healthcare and medicine, etc., but they could be a pathologist. They never heard the word pathologist, they know pediatrician, they know internist, they know family medicine, and some of them unfortunately might even know surgeon, but they never heard the word pathologist. And I think it's that enthusiasm, that way that we teach our residents, I think is our way of passing it forward so that when they have an opportunity to engage, they can say, I am a pathologist. As a sidebar, I am a clinical virologist. And until the pandemic, I can tell you for 30 years, no one knew what that was. I'm not sure they know today what that was, but we have an extraordinary opportunity in pathology now. People actually, for the first time, the lay public understand the value of laboratory medicine and what we do. And I think we have to build on that and continue to communicate that. And I think, yes, we have to co-opt the best and the brightest of our medical schools nationally into pathology as a career path.
I think it's let me hold on a second. I think it's hard to not be passionate about pathology when whether you're training a PA student or a resident, and at the end of their 3 months or their 10 months, you're like, man, they really got this. Whether you're reading their dictation and it's like pristine, it's just perfect, the details are there, or whether you go back to a colon cancer, lymph node dissection over the first couple of weeks when they're working, and you're like, man, they really did a good job here. I mean, to bring out a quality prosector, it feels great. Or to be able to read the dictation with the resident or the PA student and say, you know what, you did a nice job on this. I mean, that's where I get the passion, because if they can make that connection with, like I said, the clinical history, operative diagnosis, and gross the specimen in one time, and I have to go back to it, even if it's a complicated case, I mean, that's really motivating, I think.
Absolutely.
Which I think everybody who's a pathologist can point to an educator that they had an encounter with either in medical school or early in residency that was a passionate educator that really taught them something that stuck. And that what they taught stuck because of their passion and because of their understanding for what and how I needed to learn, or someone needed to learn at that level. And I think recognizing that and reflecting that back to students I'm working with now is really important for me.
Absolutely. Thank you, everyone. Okay, so let's sort of think back to your own sort of education path, and then attach that to the current day. So, looking back, what sort of teaching approaches did you find to have most impact on you personally as you were going through your own journey? And then, as I say, the sort of flip side of that is, which ones have you sort of taken forward to the current day? And we've talked about passion, and I think it's not really it shouldn't be an approach, it should be the standard. But beyond that, can anyone think of something particular that they found useful? I know some people learn in different ways, some people are visual learners, some people and so on. So if you could just give me a little bit of a flavor of your education journey and how that's changed your own education style. Bus, maybe we can start with you, because you've had a long experience in both sides.
Thank you, Rich. When Mike was mentioning about somebody who influenced you during your training, I just touched a very nice nerve in my body. The pathology professor in our medical school was a great storyteller about life, about his patients. And I think that created an interest in me to take it up, because he said the ultimate bottom line, final diagnosis, the Arthur Haley's book on final diagnosis, which was released around that time, late 60s, early 70s, that showed the pivotal role played by a pathologist. And I was a little uncomfortable with clinical diagnosis, the best reasonable guess based on symptoms, signs, and lab invest. But the final truth comes out of pathology. And this professor made it extremely lively for us to do that. So I've continued to tell stories, and we put about 20 of our graduates every year into the pathology program, residency program in the US system through the eras. And that's, I think, the largest number that go through. And most of them come back and say, the stories you told us, the activities you made us do in the pathology small groups still are vivid in our memory. And that's where we think we learned medicine. So what we did was, in our course, my wife is also a pathologist, and she's a co-chair. When we started at St. George's University in Grenada, instead of the usual small group slides, description, or whatever, what we did was we gave them pathology images, either clinical photographs or gross pictures. We did very little of histopathology because as a practicing doctor, general doctor, you don't do much of histopathology, but some are crucial for understanding symptom signs. And we made them create a clinical history just based on the photograph. So they had to revise by themselves the anatomy, the physiology, the biochemistry, microbiology. So they had to generate 3 clinical symptoms, explain why, 3 signs, explain why, 3 lab investigations, and explain why and what results do they get. And in the end, write a clinical vignette with a USMLE step 1 type multiple choice question. So they created a patient story based on a pathology image or a clinical photograph and wrote a USMLE type multiple choice question, which needed analysis of all these to come to a conclusion and solve a problem. So each student generated about 400 patient stories in 16 weeks of the pathology course. We run it twice a year. So that was amazing. If we outsourced the learning to them, we made them create stories, we made them do a vertical horizontal integration of the curriculum and take baby steps into clinical medicine. And that has stuck with them for quite a bit. And in these small groups, we also insisted on communication skills and professional behavior, which is generally neglected in pathology training, but we gave them grades for that. We gave them positive appreciation of those who did well, and we gave feedbacks to those who are not doing well. So I think that also helped us boost our USMLE pass rate and the 3-digit scores. Thank you.
Thanks. Anyone else with thoughts from the past, approaches that sort of
So I'll share something from the other side of the table. So maybe you guys will know what it looks like for a clinician to encounter pathologists. When I did my fellowship that many years ago in infectious disease at the University of Chicago, and I was what I would call a zebrologist. Everyone was very sick. You wouldn't be in that place. And I was a pediatrician, right? So in the children's hospital, you wouldn't be admitted to a tertiary referral center even that many years ago, unless you were very sick. And the diagnosis, to your point, was not readily apparent to us and not readily apparent to anyone else. Of course, there was no, let's search the internet and try to figure out, the 10 top things it could be. But at any rate, one of the things that I learned to do, because I had extraordinary mentors, was really to follow the clinical path of the patient. And I followed on 2 occasions. One led to actually the discovery of a new, if you will, zoonosis in a patient. Early on in my career, I was very privileged. But what that allowed me to do was to take, quote unquote, my pipettes and walk over to the Department of Pathology. So I will tell you that in a very interesting way, the pathologists at the University of Chicago and at Michael Reese Hospital in the day transformed my career, because I really understood what it meant to really try to examine pathogenesis of disease by looking at the slides. I had no idea what I was looking at, by the way, but they encouraged me. They sat at the microscope with me. We did immunohistochemical stains together for viral diseases, viral antibody, very early. This was over 30 years ago. But I can tell you, had these individuals not taken me under their wing, I probably wouldn't be doing anything of what I'm doing today. And that's because they were welcoming. So I guess my message is to everyone who's a pathologist, in addition to your enthusiasm, your patience and your guidance and your support to clinicians from other departments is really important. You just never know where we can wind up.
Thanks a lot, Amy. Any other comments on this topic?
I did have a comment, which was I could think of three things that have been very effective for me in learning as a trainee. One was actually having real responsibility. That the tasks that I was doing, I was making decisions, and I think that sometimes lacks a lot in pathology residency training. But I remember instances where I was on call and I had to choose the flow panel and call the attending and tell them what I had chosen. Um, those things really impacted me. It made me feel like I was really part of the team. The other thing was actually people respecting my opinion. I can recall there are times when I had come up with some crazy diagnosis on a surgical pathology, but that they entertained it, right? They didn't just like throw it out of hand. And sometimes I was right, and that really also impacted me. And another thing similar to what Bush had described was when I was a medical student, I did an elective in Florida. And for their autopsy rotation, what they would do is for their conference, rather than have the person who did the autopsy present, the other residents actually had to present the autopsy, and they would ask the prosector questions like how much did that heart weigh, but they also similarly had to go back and discover and say, okay, looking at these kidneys, did this patient have diabetes? And it was so interactive, and really I felt engaged in that process a lot more than if I had just been sitting there listening to the person who did the autopsy tell me, oh, so and so had died at age 45 or whatever. It was those sort of interactive instances were great.
Thank you. Any comments, Mike?
Yeah, I think the common thread amongst what several folks have already said that resonates with me is that, as a learner, I learned the most when I was put in the position to actually think through something. And so when I'm teaching in virtual interactions in particular, I'm really trying to get my thought process that's in my head out to where the learner can understand it. And I know it's hard to make virtual interactions interactive, but with things like quizzes and videos, you can make your thinking clear and then challenge the learner to understand that process and go through it themselves.
Thanks, Mike. Actually, that's a great segue into the next portion, which is, I think no one would disagree. I think that education has evolved a great deal over the last couple of years. COVID-19 aside, and because that will be the next portion, but aside from that, what do you think have been for you the major changes that have made things better? And I suppose crucially, what things may have changed that have made things worse, do you think? So what are the sort of the pros and cons of recent changes?
I'd say as far as one of the major changes for me that I've seen kind of over time is we don't have any books or manuals in the grocery room anymore. We don't have any Lester or Ruban or anything like that in the grocery room as far as resources go. Instead, we have it all on a network folder, which is easily accessible and faster and easy to add and put things into the network folder and make that a resource for the PA students and the residents. That's been one major change that I've seen, because back in the day, I mean, we pull out a book and do blood all over the the grossing manual or whatever, and now it's all online. So that's one of the biggest changes, and I think it's very efficient and it works out well. I can't really think of anything negative at the moment.
Bruce, go ahead.
Thanks, Rich. I think a couple of things had already developed, which were very helpful before the COVID hit us. One was the online resources, like the Instagram, the Twitter, the YouTubes. So much information is available there. Mike was referring to Kamran Mirza. Yeah, he's one of the great guys who has advanced this virtual teaching of pathology or digital pathology with his group. So pathology residents in different, since we are talking on a global perspective, I know the situation in India. I go there every 6 months with some students and spend time there in a hospital. Many of them don't have faculty resources to bring them up to the level where they need to be. Many of them don't have technological facilities in their institutions. Many institutions don't have autopsy services. So the digital revolution had already brought many things available as long as you have an internet facility available at your location. The second thing is, I run back to my medical students teaching. It used to be very difficult to teach a large group of students without figuring out how much they have understood. If you ask a student a question, he or she will be put on spot. It's very embarrassing. They don't want to give a wrong answer and be made fun of, etc. So we had these audience polling systems that came up, like Who Wants to Be a Millionaire? I don't want to use a company's name, but now free software is available. Students can respond on their phone, and you can get a collective feedback of the whole class literally instantaneously during your lecture. And then you can correct any misconceptions that are there. So at the beginning of a lecture, you can lay the foundations with a few questions on what they need to know. Middle of the lecture, all the way through the end, you can do several clinical vignettes with pathology-based questions, give them time to think and they respond. You can correct any misconceptions. At the end of a unit of instruction, you can really do a summary evaluation of total comprehension of the different aspects of that particular topic you're taught. And of course, earlier, like Jason mentioned, we had to give everything as printouts, hard copies, and that was a nightmare. All the teaching information, your learning objectives, your teaching material, etc., can be provided online. The lectures could be accessed by them later on. They can go at their own speed and figure out. And so there were these technological advantages even much before COVID hit, and we could exploit them, especially with the Zoom once COVID hit. Yeah, thanks.
I think one area for improvement in pathology right now is the fact that faculty we aren't really trained to do these things, right? We trained to be pathologists. We didn't necessarily train to be educators. And there are a lot of new modalities, flipped classrooms, self-directed learning, team-based learning, but we don't necessarily know how to implement them. And many of them actually require a lot of support. It takes a lot to get a team-based learning just one session off the ground. So you need institutional support to drive these kind of innovations as well in education. I think it really could be great for residency training as well as medical student training, because this generation has grown up learning that way. And really just having didactics spoken at them doesn't really work very well for their learning. But we definitely need to invest in faculty development and perhaps maybe nationalizing some of the availability of certain content. I mean, one of the things we're dealing with right now in the United States is there's a requirement for training on healthcare disparities, on diversity and inclusion, and we're all on a learning curve just with the residents. We're not the experts yet, so how are we teaching it to anyone? So I think there's definitely a need for faculty development nationwide.
Thanks.
So I want to comment about just two things, and maybe this will dovetail on what Tiffany said. The first thing is this business of online learning. I think it's great. I'm a visual learner, so I love YouTube, right? I've learned how to fix almost everything in my house in the last year and a half, courtesy of YouTube. Maybe I've broken some things, but we will not go there for this session. But the more important part is, and I think this is the cautionary tale, and I think that Tiffany touched on it, we put things up online, we record. And there's this great cartoon strip of someone walking into a medical school classroom, even before COVID, and all they see is 150 tape recorders. Parents say, and students say, what am I paying $90,000 a year for a tape recorder? I think it's dangerous if we're not cognizant of the interactive part. I think that if we don't mandate a Q&A session that goes along with the recording, if we don't mandate attendance and accountability, that's my new favorite word, by the way. If we don't mandate that, then we're going to miss a whole bunch of individuals. And to the point of how do we assess engagement? Well, if they're not there, and they're sitting remotely and they're trying to, whoever the they is, and it can be faculty as well as students at every level, because yes, I agree with you, we're all learners on this journey together, then we haven't fulfilled our responsibility. So I think we really have to pay attention to that, and as we teach. And yes, our institutions across the United States are actively working towards how do we teach better, more efficiently, more carefully, and motivate those that we are teaching. But we are really at the beginning of this journey. I mean, maybe some more into it than others, but we have to be very cognizant of the limitations. The other side of this is in laboratory medicine. And this is something that I deal with in a different way because of the constraints on us by the inspection entities who shall remain nameless. We are very limited in what we can actually allow residents to do in our laboratories. And I don't know if anyone on this call recalls the day when the internal medicine resident would actually go into the microbiology lab and do a gram stain with the micro supervisor. Well, that ship sailed. Not only did it sail for the internal medicine resident looking under a microscope, it's actually sailed to a large extent for our pathology residents as well. So I think that with everything we've gained, there are losses, and we have to figure out how to compensate for those in a very efficient, careful way.
Thanks, Amy. And I suppose that's a good point to bring in the COVID-19 situation, which I think has accelerated some changes, made some things impossible, made other things more palatable. And I think we can dwell briefly upon the impact of COVID-19, but I suspect the story will be similar for most people, irrespective of how involved they are in pathology education. But I think let's have a little bit of that, but also I think more importantly, what changes did COVID-19 bring, or what were the impacts of COVID-19 that you will take forward in a post-pandemic world? So what lessons have we learned from an education perspective? And this sort of the reason why I think that dovetails quite nicely into what Amy's just said. Some things we want to quickly forget, but other things we probably need to hang on to, and we probably also need to analyze other things that have happened. So Mike, you didn't have much to say on the last one. Maybe you can kick us off with that particular question.
I think the biggest thing that changed for me during COVID was, I'd before COVID, I'd started using polling software. I'd dabbled in some virtual things, but those were really focused at kind of one-off experiences with small groups. And I think the big thing that changed for COVID with me is that I've really tried to work on things that have targeted larger audiences. So developing the pediatric pathology module for Pathology is part of that, and make something that's self-contained, interactive, has some evaluation to it. I think things like that are going to be really valuable going forward. But I've also not only tried to look at bigger groups, I've tried to do some smaller group things. So we've actually hosted at our institution a virtual observer internationally who came to our institution virtually every day for a month on Zoom and got to preview cases with our fellow, got to look at them, think about them. And I'm hoping with future observers that if we can get them computer access, that it could be like that they're on site. They could write cases up, they could look up clinical histories, they could review the labs, the history, and do all of that thing. So I think I've kind of gone in two directions, that I'm looking at more tailored individual experiences that we can make available to people that wouldn't necessarily have the opportunity to travel to my institution, but also make things that are larger programs that can target big audiences and endure on their own after the pandemic.
Thanks, Mike. Any other thoughts on that question?
Yeah. So one thing that how COVID really affected me educating the residents and PA students is that during that whole entire time, there was a lack of specimens. And so I had to really work extra hard, because my whole goal is to make sure there's like a list of specimens that I want to make sure that the PA student, especially the PA student, because the resident, by the time the resident gets to us, they've already been on 2 rotations. But the PA student for 10 months during the COVID pandemic, man, I was just grasping for every specimen I could possibly find to make sure they get that list completed. So by the time they got done with their training, they would be, in my mind, ready for the real world. So the whole COVID experience for me actually, I mean, I was able to kind of finalize all my network folders and just really dig deep and try to just make it the best program I can make it. And I think that COVID thing really made me grateful for, the time that there was not a pandemic, when basically they would get every specimen there was to get. And so I'd be like, sending specimens from this place, from that place, to make sure that student got that. I know it's silly, but ganglion cyst, or whether it was a thyroid for a thyroglossal duct cyst. I mean, in my mind, I wanted to make sure that they got everything that the past students got. So when they got out in the real world, they'd have a job, and I was lucky in that sense that I was able to get the majority of what they needed. So I guess the whole COVID thing, just really having the extra time to work on the network folder, education, and the videos, I really got it down to I feel like an art now, and so that was good.
I agree with Jay. Having lived through that scenario here and having to redeploy people to different laboratories and having some residents who couldn't come in for health reasons, has just made me think strongly about contingency planning and wanting to have something in my back pocket if I need to create a virtual experience for someone. So one of the things we are going to be trying to do is get all of the teaching slide sets digitized so that people can review those when they're at home, if they have to be at home. And like Mike said, also setting up a virtual elective. I've been corresponding with Marissa White at Johns Hopkins, who created an extraordinary digital elective for medical students that used whole slide imaging, that had set times that they would sign out with her during the day, and they had their own cases to write up. I would love to implement that for both visiting students and our residents. I think I want to incorporate something like that as part of our online onboarding so they can practice writing up cases, because that's not really in it yet. But just thinking about, I need to have a contingency plan if something like this ever happens again, or even if just somebody needs to be at home for a certain period of time for health reasons.
So I'm going to share something very interesting that happened to us at Montefiore, that actually we just submitted, and the paper I think is out already on what we did in our command center. We utilized MD, PhD students to help us with our command center and our laboratories, in addition to the residents that Tiffany and colleagues deployed, and our colleagues in surgical pathology who stepped up in an extraordinary way to help us in our clinical pathology labs. And a few of them hadn't been inside of a clinical pathology lab in at least a decade. So I personally was very busy building a virology lab and expanding our footprint in 4 days, I kid you not, with a very extraordinary group of people. But we also set up a command center. And what happened, which was really interesting, and maybe there's a lesson to be learned in this, I think there is. Traditionally, we don't get that many, at least in our residency, of our MD, PhD students. But because of this experience, there are now 2 that I'm actively engaged in conversation with that are actually rethinking their career path. They're going back into their clinical years now. They've completed their PhDs. They were stipended, so they were allowed to work as part of our command center. The regular medical students were not, and I just want to make that very clear. But because of this experience, working literally with our clinical pathologists and our pathologists that were deployed, they're really thinking about pathology as a career trajectory now. And if they're already committed, they're thinking about, wow, internal medicine and pathology. Like you, Mike, I don't know if you did peds before, peds path, but they're thinking about now, what can I do with my internal medicine and pathology or laboratory medicine? So there's a message in there. And I think the message, at least for me, is more exposure early on on the floor with people like all those people on this call who really do the work, because it would be fantastic to just get more people engaged in pathology early on in their careers.
Thanks, Amy. That's a good point, and it actually, I was going to address this later on, but now is as good a time as anyway. But I think in many regions in the world, pathology and laboratory medicine do have a bit of a pipeline problem. You've just sort of shown one sort of unexpected example of what could help. Has anyone got any other thoughts on that particular challenge? I think we've touched upon it in several ways already. One is having passionate educators. One is having interactive learning experiences. Any other thoughts on that pipeline problem and how we get more people into this great field?
So I think a lot of medical students dismiss pathology as a career based on misconceptions and that lack of experience. And I really am hopeful that things that have happened during the pandemic that have grown up to give broader access to trainee audiences to lectures and experiences in pathology, I really hope that's going to help reverse that. And Tiffany mentioned whole slide imaging. I think that is a tremendous tool that, because of the cost involved in the setup and storage, is probably so far underutilized in giving that opportunity to trainees and medical students. I know some universities have transitioned their histology courses, if they have a histology course still, or if it's just integrated into other parts of the curriculum, but they've transitioned those to whole slides. In my program, we're trying to really build out our virtual slide library for the residents. And I think, things like that make those opportunities available to medical students early on so they can understand what we're doing, what we're seeing, what we're looking at. And even on rounds, if they're doing a virtual conference with the pathologist to see the slide, anything we can do to give them some idea of what we do is really going to help get more people to understand and be interested in the field.
I think there's still, oh, go ahead. I'm sorry, Bush, go ahead.
No, go ahead. No, one of the informal ways we had introduced this during my initial 18 years in India was that there were daily biopsy rounds like liver, GI, bone, female genital system, etc. And there, the clinical residents were, during the rounds, were asked randomly to present the biopsy, and the pathology residents were randomly asked to do the clinical. So we had to read both the clinical files as well as the biopsy. Those were initial years when there was an explosion of knowledge on renal biopsies. It went from acute glomerulonephritis to subacute to chronic to all the various subtypes and the immunofluorescence and EM. And when these clinical residents went to distant parts of India to set up their own nephrology units, they needed to know pathology pretty well because they had to update their pathology people on the recent thing. So even if we don't have a formal liaison between internal medicine residency and pathology residency, all the interactive sessions we do, if we shift responsibilities between the pathology residents and the clinical residents, it goes a long way in finding out how each segment walks, and that will make them more well-rounded pathologists or clinicians. Thanks.
I was just going to say that, I think the biggest thing that's really helped let everybody know about pathology and whatnot is the social media stuff. Because back in 2004, when I first started doing this, if I was to put a picture on whatever was back then, Facebook or something, I'd be reprimanded. I'd be in trouble for putting a picture of an appendix or something on Facebook. But now with social media, it's all over the place, and so many people are finding out about pathology and forensics and that kind of thing. And that's been a great, a big thing that's happened. I mean, I'm personally not on, I don't put anything on social media, but there's a lot of PAs that I know that put stuff on, and it's amazing. It's like, wow, she's really, he or she really knows their stuff. So anyways.
I totally agree with that. We just had one of our chief residents got their per blue check verified on Twitter, and she actually gave a workshop to the residents and to the faculty on, the ins and outs of using Twitter and how to be savvy about it on this whole Path Twitter hashtag. The other thing that we've done is over the past few years, excepting last year due to COVID, we offer a first year at the summer of medical students' first year um, path experience, and it's paid. They get a small stipend, and we set up an opportunity for them to uh, work with us in pathology, but also it's really tagged to following a patient. So for example, they might be in the endoscopy suite in the morning and in the afternoon looking at the biopsy. So they really get to see what the clinical importance of what we do is. They get to attend the lectures and such as well. And another thing that the medical school just began piloting this year is at the end of the second year, there's now going to be a transition to clerkships block of time. And within that time, they've included pathology. So this year we did a session where we kind of introduced them to the laboratory because we feel everyone should be, you know, educated about how laboratory works, know what's the turnaround time, things like that. So they get an opportunity to get exposed to laboratory again at that end of the second year before they enter the wards. And the people who've gone through the first year program, we've had some people who actually have gone into pathology. We also have a pathology interest group at the medical school. And it's been very important for us for that to be really functioning well, to have our residents be involved in that group. So we usually have one or two residents who are really enthusiastic about recruiting people to pathology, and having them be the liaison with that student group is really important because they get the boots on the ground of what it's really like to train in pathology.
I think social media has not only been important in giving medical students the opportunity to see cases, and what we're working on, but I think it's also helped to dispel some of the myths about who pathologists are. And I think the opportunity to have that interaction with huge numbers of people across the world and give the audience, an opportunity to see who we are, what we're doing, what we're like, and push aside some of those stereotypes about personalities that would go into pathology. I think that's been really helpful as well.
I agree with you. I'm actually working with a few faculty right now on doing, again, it's all about speaking, effective messaging, but about literally doing global lectures. And figuring out how to do these virtual lectures across the globe. But it's not only about your talk, it's about really understanding, to the points all of you made, where the gaps are in the community that's engaging you, because it's not the same. I mean, we live in a urban area in New York City, which I have no doubt is different than all of what everyone else on this call, experiences in their practices of pathology. So I think it's really important to stay engaged with colleagues across the globe and figure out how each one of us can help each other and carry that message forward, regardless of where the individuals ultimately practice. I think that this community needs more members, I guess is what I'm saying. And as our faculty are starting to think about our senior faculty retirement, we seriously have to think about what the young folk who come into pathology are going to do, and how are we going to make this interesting. And to your earlier points, I mean, my image going back many years of a pathologist was not appealing. So clearly I dismissed pathology out of hand in medical school all that many years ago. And it wasn't until I had a reason to go back and visit my colleagues in the Department of Pathology and found them, wow, they're really cool, interesting people who knew a lot of medicine, that I said, wow, maybe I can think of a way of doing this as a career. So for me, it became lab medicine. But I think that that's important. We have to stay engaged, and we have to really share our message that what we do is important and it's as vital as anything else that everyone else is doing.
Yeah, I think there are several groups who are already working on these global lectures to help pathology residents across several countries. I know 3 groups in India who do it, and the students, the residents can see it at their leisure. They're available on YouTube. My concern was the overabundance of material in social media. We have gone through the hoop now. There's so much available. And like Wikipedia, we need somebody to review what's available. And there is a toxic dose. We don't know what's right, what's the latest, and how much is anecdotal and how much is really scientifically proved. So maybe we'll be moving towards a situation, say, pathology resident somewhere in a country XYZ is looking for some information. There should be some international body will say, these are peer-reviewed good articles or good lectures you can go through. And so because there's so much material, people get lost. Thanks.
That's a great point. And I think that's been one of the strengths of what CAP has put together, is that it's really recruited experts and tried to make those lectures widely available. And I really hope other societies in pathology continue to support models like that, where they're putting their stamp on some of that educational material.
Thanks, everyone. We'll switch gears a little bit now and get into some specifics. I'd like you all to share your personal favorite teaching tool. We'll have a little snapshot of if there's one tool that you go to, what is it, and perhaps why. Jay, do you want to kick us off there?
Teaching tool. Well, I have something pretty basic and simple that I hand to the next PA student every year, and it's still intact, still together, is a big white clipboard and a bunch of vis-a-vis markers. And this is a great thing for me because, after the PA students been with me for a few weeks, and they start doing more complicated cases and stuff, I'll basically just say, hey, you know what? On this case here, you tell me what's going on. I want you to write down on this, dry erase board any details of the length of the specimen, what pathology is going on, and then I'm going to come over and you're going to tell me what you're going to do, how you're going to sample it, what things you're going to make sure you mention and don't mention, and the pertinent negatives and positives. And I mean, this clipboard I've had it for like 5 years. It's still intact and it's stained and everything. And I always, of course, disinfect it for the next student. But this is something that stays, in the grocery room, obviously. But it's great because, I mean, I can just say, hey, okay, you tell me, and I'll go over there and I'll look at the dry erase board and they'll talk to me about it and whatnot. And then they have all the information they need to put the dictation together. So this is something really simple, but it works well. So there you go. Uh-huh.
Anyone else?
Hi. We use a tool called concept mapping. And this is to push students who are superficial learners towards deep learning and interactive learning. So at the end of each unit of instruction, we train our students, and then we mandate literally every student to draw a concept map, which brings in the pathology component, correlations with clinical, what are the associations, how they are connected, how, even in the basics of pathology, like different types of necrosis, which organs you see fat necrosis, which you see coagulation, how will it connect with lab investigations, how will it connect with clinical features, etc. And through this concept mapping, they put a whole lot of associations which are important clinically for them. And these concept maps help them to wade their way through when they are stuck at one point. It can be used as a self-learning tool by students. It can be used in small groups where we have concept maps with gaps and they need to discuss in groups and fill those gaps. These can be used as evaluation techniques where, instead of taking a multiple choice question, they need to draw a concept map to show how they have understood the different associations and correlations. So I think that's a great, and if I had to choose one tool for a pathology student, that's a great tool to make them understand the importance. Thanks.
Thank you. Any other comments?
Well, I'm a surgical pathologist, so most of my teaching is at the scope, and I guess my main technique is kind of stream of consciousness, so I really want people to understand my thinking process when I'm going through a case. So I'm not afraid to tell them, as I'm looking at a case, for 1 second, I might think it's something else, and I can completely say, oh, wait, no, this is why I've changed my mind. And it just forces me to say what my thinking process is. And then similarly, I ask questions. I ask things about, why do you think I might think it's important to know when the LMP was on this case, or if there's any progestin, if the patient took progestins. I like to ask questions. I do think we're still allowed to do that these days. Just ask them politely, and if they don't know the answer, you don't keep badgering them about it. And then the other technique I really like to use is actually giving people chances to make choices themselves. If I've worked with somebody long enough, I start asking them to tell me, okay, so what levels would you order levels? Are there any stains you'd like to order? And really listen to what they say and have a discussion about it, because they should start to get used to making decisions as surgical pathologists.
Thanks, Tiffany.
As clinical pathologists, I bring the same skills that I learned as a clinician to my teaching. It's very similar to what Tiffany described, but it's not at a microscope. So I use the equivalent of a whiteboard, and I actually tried to learn how to teach using the whiteboard on Zoom. So I'm about 80% there, not 100%. But I find that the interactive is key. That's the way I'm most comfortable teaching, and I've managed to translate that whether I'm teaching one-on-one or whether I'm teaching to 500. And that was something that I had to learn to do in the large space. And I think Mike talked about that, small groups and large groups, and how to translate that interactive experience, whether it's a one-on-one, a seminar of 20, or a room of 500. And I think that that's what works for me, and allowing people to weigh in and to share their thoughts and to not be judged. And I think that you will raise that, and that's critical. But that free interchange of where your mind is going and what you're thinking about is really important to have a learning experience that lasts, that endures.
I'm a lot like Tiffany. My favorite tool in my office is the couple of trays of slides I have where I've built some similar cases into sets, and I'll talk to those with hopefully small groups, generally one-on-one with residents, and give them a case, tell them a little bit of clinical history, and then make them ask every question about that case. What do you want to know about the clinical history, the imaging? Okay, now what's your differential? How are you going to work that out? What tests are you going to order? Okay, here's the results of those tests. What do you think it is? And just make every case a top to bottom experience about their thinking process, and tell them how I would think about it, help them fill in the gaps about their thought process. And I've got a couple of those trays organized into things that are similar so that they have to kind of go through each branch of that decision tree while we sit down for an hour or so and look at those slides. And I've gotten those slides digitized in the past years, so I'm looking forward to leveraging them even further.
I think for the medical students, one of the other tools which is very handy is using flipped classrooms. That's one of the things we sort of learned through this COVID situation. They're not interested in sitting and listening to you describing something. So we provide the learning material in advance. And in the class, it's a series of questions and problems which they have to address. And with the audience polling system, it's so easy to run through several concepts in a given unit of time and give them an idea of where the lacunae are in their understanding and reinforce what they have learned very strongly. Thank you.
Thank you. Okay, we're coming to a bit of a close now, so I've got a couple of final questions to round things out. First one, what key message would you like to share with other pathology and laboratory medicine educators? If they take one thing home from our interactive session today, what would you like it to be from your point of view? Tiffany, maybe you can start us off on this one.
Well, off the cuff, I think one of the things that we really need to drive to in pathology is giving our residents more opportunities to have real responsibility while they're training. That's going to make them prepared to enter the workforce and feel confident that they know how to do their job.
Thanks. Buzz?
I think it's the change in the mindset. Do not think of yourself as a laboratory pathologist sitting in a basement, putting diagnostic labels to a slide. think of yourself as a clinician and a clinician educator, because many times, classical example is bleeding disorders. There are more than 35, 40 tests. Clinicians order it easily because on the computer it's a tick, 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 tick. In the end, they don't know whether to increase the dose of heparin or decrease the dose of heparin. They call you up. So you are an educator of the clinicians, and you are responsible for more than 75% of the management decisions in the hospital. So once you put yourself in that mindset, your teaching of your medical students or pathology residents will take a whole new meaning. Thank you.
Thanks. Jay?
I think it's just very important to find out whenever we have a student or a resident, to find out where they are in their education as far as what they have and have not done, and try to kind of come to a completion, or try to come to an end where they've experienced as much as they can experience. And an example, if you have a resident that comes into your so like I was saying earlier, we have a pathology resident that comes to us at the end of the rotation. They've been to 2 other rotations, and I've had residents that come in and they have never even done a mastectomy, or they don't know what a radial margin is or an APR is. And so I feel like as an educator, it's your job to make sure that they get, as best to your ability to be thorough, and make sure that they experience as much as they can, so they can be a good prosector and good diagnostician later on.
Thanks. Amy?
Many years ago, when I was a young house officer in pediatrics, I sound really ancient, and it was several decades ago. One of the best pieces of advice I ever got from a colleague who was one of my mentors, and obviously someone who made an impression upon me, was don't ever leave the room before you ask, what else can I answer for you? And I think that that applies to every aspect of my teaching. When someone is working with me, and especially in a one-on-one situation, and I think everyone said this, I never presumed that they understood every piece of communication that went on in that room. The last question before they walk out my door, and this is true for faculty as well, not just for residents, is, did I answer all your questions? Is there anything else I can answer for you? Their response may lead to an assignment, a follow-up visit, another hour of time that I probably didn't have to give them. But I think for me, that's so fundamentally important when you are working with someone and you're trying to teach them something that presumably they didn't know before they walked into your space.
Thank you, Amy. And Mike?
I think what I've seen in the last several years is that there's a number of really great educators who've gotten onto social media and posted cases and engaged with people and had tremendous responses from the audience on social media. And I think those individuals have found that to be a very rewarding experience. And more so even now, with everyone's ease with Zoom and other virtual interactions, there are just so many opportunities for people to get involved, to put themselves and their teaching pearls out into the world. I would really hope that folks take away that there's just so many incredible opportunities right now to engage, and particularly through social media. And I know there's a lot of really good educators in pathology who haven't taken that step. And I really hope they would think about this as the time to start to really put themselves out there at any stage in your career. Put yourself out there, give those opportunities to students, to medical students, to residents, to get to know you and to see the incredible teaching material that you have in your office.
Thanks a lot, Mike. Some great words of wisdom there. Okay, well, I think that's all we've got time for today. So, mainly I want to thank all of you for your invaluable contributions today. It's been a great discussion. I feel like this could have gone on for another half hour or hour or so, but we'll keep it brief and maybe revisit it another time. I think it's clear that pathology training and medical education in general is evolving. I think it's having to evolve, and I think there are some educators out there that are clearly staying ahead of the curve, and I think we've got those on the call today. I do hope that everyone that's watched has found this educational, and that you're able to take some lessons back to your own classrooms, as it were. Once again, I'd like to thank our panelists. I'd like to thank our sponsor, CubTech. And from everyone at the Pathologist, thank you for listening and stay safe. Thank you.
Thank you.
Thanks so
Thanks, Lee.
much. Thank you for the opportunity.